Hello, my name is Dr. Sarah Walker, and I'm honored to serve as the 2025 President of the El Paso County Medical Society. On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Kathrin Berg.
A colonoscopy, one of the greatest gifts you can give yourself to save your life, because by removing suspicious polyps during the procedure, cancer can be prevented. During this next hour, we have physicians talking about the importance of early detection, about diagnosis of colon cancer. This evening's program is underwritten by Tenet, the Hospitals of Providence, and we also want to thank the El Paso County Medical Society for bringing this program to you since 1997. I'm Kathrin Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Thanks again for joining us. Tonight we're talking about colon cancer and the importance of early detection. Through the last decade or two, we've all been hearing about actors, people who are celebrities who have been diagnosed with colon in their 30s and their 40s, and some don't make it. Years ago, that was something that we didn't even start screening until the age of 50. So we're going to talk a lot about that tonight. Maybe have some special guesses, educated guesses as to why, some research that's going on but continuing there. But tonight, that's what we're going to be speaking about. So with me, I have Dr. Arturo Hernandez, who is a family practice physician, and he's been in El Paso for about 15 years. I don't want to steal your thunder because I'm going to ask you guys to introduce yourself as well. And then we also have Dr. Avery Walker, who is the colorectal surgeon on our board here today. So Dr. Hernandez, I would love for you to talk a little bit about what you do all day, every day for our audience.
Okay, I'm a primary care physician, so we are the gatekeepers, of the health. We're trying to prevent, and that's why I love the way you present the colon cancer, because it's one of those things that you can prevent. Mm-hmm. If you catch it on time, the patients, they have a much better outcome if you catch it in a later state. Exactly. It's very important. I think the reason we're here is because we need to emphasize in prevention. Instead of surgery or large surgery. Dr. Walker is going to talk about all that, but I think it's very important, the prevention in this case in colon cancer. It makes a big difference.
Completely agreed. And there was a traveling colon in town lately, and we'll talk a little bit about that too, but it was really cool because you could see life size, like literally, not life size, much larger than life size. You can kind of walk in there, see what a polyp looks like, see what is normal, what isn't normal, et cetera. So it's always nice to be able to see that. Dr. Walker, let's talk about you. Again, you're a colorectal surgeon.
Correct.
And we were talking a little bit prior to the program that you were in the Army for a while, so you're kind of from everywhere.
Yes.
But give us a background of why you got into colorectal surgery in the first place.
Sure. So like you said, I was in the Army for 13 years, and I trained as a colorectal surgeon, initially as a general surgeon, got my fellowship within the Army, and practiced colorectal surgery here in El Paso for about 5 years, and then stayed in El Paso when I got out of the Army and continued as doing my colorectal surgery practice. And I love it. It's a wonderful place to practice, and it's very busy. And just like we're talking about, prevention is the key, but I do love to operate, and I will operate when I need to.
I will operate when I need to. I like the way you said that. Prevention is the key. I love that. We were joking before because you said you were here since 2017. If you were a grown up in El Paso type of a person, we usually say, oh, where'd you go to high school? That doesn't count for you. So now, if you were an implant, we get to ask you what your favorite Mexican food restaurant is. Don't answer now, but maybe before the end of the show.
Perfect.
And you might have some people rah-rahing, or some people are like, we need to take them somewhere else.
Right.
So let's talk first about what the colon does. So we hear colon cancer. Sometimes we hear colon and rectal cancer at the same time during the same wording, but you never hear small intestine cancer. You never hear, not often do you hear stomach cancer. You don't hear these other words. So Dr. Hernandez, I'm going to ask you first, what is the role of the colon? And why are we seeing colon cancer versus anything else in the digestive tract that kind of takes over? It's like colon cancer is the most prevalent.
Of course.
There are other ways and places to get cancer, but why is the colon the superstar there?
Because it's the third cancer in incidence. So basically, and also very important, we need to emphasize that we're seeing patients, younger patients every day with colon cancer. Like you said before, the standard of care, it was the colonoscopy by 50, but since 2021, the guidelines, they changed to 45 because we're seeing younger and younger patients with colon cancer. So I think that's very important, to emphasize on that, That is the third cause of cancer, and is the second cause of death by cancer in the United States of America.
So this is a hard question to ask because I don't think there's a real answer yet. And I'm going to throw this out to both of you, but since you started, the incidence of younger diagnosed colon cancers now. And usually there are no symptoms, and that's the hard thing. It is a silent cancer that kind of creeps up on you, and sometimes you don't know anything until you have had the screening. So on that end, the guidelines now are at 45. However, if you've had other risk factors, what are those so that people who are listening and watching go, you know what, that's a risk factor. Maybe I can talk to my doctor and see if I can get screened starting at 40, maybe even at 35 if the risk factors are there. What are some of those risk factors?
Sure.
Dr.
So
Walker?
what I tell a lot of my patients that I see, when I see my patients, they're already having symptoms, typically. They've seen their primary care doctor and they're having the symptoms. And those symptoms could be anything from abdominal pain that's not getting better. It could be bloody stools that they're having. It could be constipation. It could be bloating. All these things that people will think of that are normal until they're not. And so what I tell patients are, if you're having symptoms that don't get better on their own, see your doctor and tell them that. And then if the primary care doctor says, well, let's try some things, and they don't get better, then the primary care doctors say, you know what, we need to do a little bit more work and get you a colonoscopy. Typically, your constipation, your bloating, your maybe some blood in your stool, typically will go away for healthy people.
Right.
But if they don't,
so as
that's
you're
where
saying
you
that, and this is me being a disruptor, because sometimes I'll miss the point. So when these things go away, and the reason I'm saying this is I want to be very specific, not cause alarm, but do make things very serious. If you're having issues like that and they go away, what could have those causes been? So there's IBS, there could be...
It could be anything. It could be something you ate, right?
Okay.
It could be a virus. It could be some bacteria that you picked up somewhere. It could be anything. But if those things get worse, or you're starting to have worsening symptoms, weight loss, you're starting to have fevers, something that's just not the normal kind of course of action when it comes to just a simple sickness, that's when you talk to your primary doctor. The things you tell them may, convince them to say, okay, you need something more than just some medication. You might need a CT scan. You may need a colonoscopy. You may need something that we can start looking. And we can't push these patients away, because a lot of times back in the past, we would say, oh, it's no big deal, and then sure enough, it would be a big deal. And so anybody who really shows up in my office with any problems, they're getting a colonoscopy. And
I like the way you roll.
because by the time they've gotten to me, they've gone through their primary care doctor a couple times. And at that point, I'm not going to turn them away, because my colleague here has probably done a lot of work up at that point to say, hey, this person I'm concerned about, I need you to do the extra work to find out what's going on. And the worst thing that could happen is that you don't find anything, and that's great, right?
Yeah.
Because that means we did all the work.
Exactly. And I'm going to cover too, and I just so people are listening, we are going to cover too the topic of hemorrhoids, of IBS, of diverticulitis. We're going to cover all that. So if you're kind of wondering, okay, my doctor said I have a couple of these things, we're going to cover that in the area and mapped also as colorectal cancer. Go ahead.
And the risk factors, first of all, it could be age, we're seeing a surge in colon cancer in young patients, but still the majority of the patients with colon cancer are about 50 years old. So age was one factor. The other one, it's also diet, you know, red meat, processed red meat like hot dogs and stuff like that. You know, those are risk factors as well, you know. And the other thing, it's very important regarding the risk factors, it's a family. You know, if you have a family history of colon cancer, unfortunately, it's one of those cancers that they run in families. So it's very important to go to your physician and let them know. Another risk factor that it's also besides is obesity. Yeah, unfortunately, here in the United States, we have a obesity pandemic, and that's one of the also risk factors. You know, a rich fat diet, a big factor as well. So if you see, there is a lot of, it's multifactorial. It's not just one thing. Right. It's multifactorial, and that's why it's very important the prevention. You know, with diet, exercise, and all the stuff. But all those are very important. There is also some basically genetic component of it. Those are not very common, you know, like Lynch syndrome that is associated with other types of cancer.
That. You're right.
Those are more specific, and that's why it's very important to address it with your doctor. But if you see, the risk factors are not super special, you know. They are very common things. Our diet, it could be a factor. So that's why it's very important to emphasize in that.
So I want to bring somebody up who's here today, who happens to be a family member of yours. And so there's a couple of pronged attacks here. So number one, she's going to find out if she's going to be admitted to nursing school. Yay, Valeria, hi.
Hopefully.
Yeah, we'll see. But number two, how old are you? Do you mind if I ask you? They're 19. You're 19. Oh, your life's in front of you, darling. I love everything about that. So Valeria then has probably grown up with processed foods. By no fault of the family, by no fault of anything, it's just kind of our society now. It's really easy to either get fast food, even in the grocery store, the packaged stuff that you get right and left. I was just visiting my kids in Austin, and the HEB, they have like literally green onions cut up, put in a package on the shelf. And I'm like, okay, is there some kind of, preservative in there, etc. So when you're talking to young 19-year-olds, your daughters, family members in general, because it is now a newer diagnosed disease in younger patients, and from both of y'all, what are you telling people? What are you telling the young ones in nursing school? What are you talking about the medical students are coming up? Because it is a whole different field than when we were growing up.
Yeah. Unfortunately, I don't think we have very good discussions about diet enough. We don't have a lot of time with our patients because we're very busy. And so to sit down and have a detailed discussion about what they're eating is difficult. That being said, just like you said, the processed foods are just everywhere. And we think that might be the reason for this. There isn't good data to say this is the answer, because if it was, we would be able to prevent it, right? But it makes sense. And so to try to avoid the processed foods as much as possible, that's what we push to the patients. You know, green leafy vegetables, try to stay away from the packaged foods, try to do your own cooking. We're all very busy, it's very difficult, but to stay away from those, packaged foods and processed foods, that's, I think, a big factor in why we're seeing younger patients with colon cancer. But it's not guaranteed, because you can talk to 100 different patients who do eat those things and they don't have colon cancer. But the one person does, for some reason, has some predisposition to getting colon cancer. And so it's just best to avoid those kind of things if you can, and that's what I push to my patients. A lot of my patients come with constipation, with hemorrhoids, as you mentioned, and a lot of that also has to do with low fiber. We get very low fiber in our diet in general, and it's very hard to get the amount of fiber that we recommend in general. So I constantly push fiber to all my friends and family and all my patients. And when you ask them how much fiber they get, they don't know. They think they got that whole wheat bread sandwich and that's all the fiber they need, and it's nowhere near.
So I love that you're saying that. So be specific on what they can eat more of. So we all hear it, more fiber, but what does that mean? So there are supplements, there are fiber supplements. We can do name brands or not, it's up to you.
Yeah.
But to your patients, what do you tell them?
So fiber supplementation absolutely I think is appropriate, specifically Metamucil or psyllium husk, but that can only get you you about 5 grams of fiber. We recommend 30 grams per day. So if you're only getting 5, you got 25 left to get somewhere. And so what I always tell patients is try to get something green in every meal of the day. And that can get you anywhere from 15 to 20 grams a day. And you have to actually make an effort to do that. And that's hard. You know, people don't like to eat salads. People don't like to eat green things. I tell patients I do it myself. I take a shot of Metamucil every night before bed. And then I also
repeat that, because people are going to listen to the
yeah,
show.
I literally
that colon cancer
it's
guy,
part of my
he said,
it's part of my nightly routine. I take a shot of Metamucil right before bed, follow that with some water, and then throughout the day, every meal I have something green, whether that be broccoli, beans, peas, something like that, something with high fiber. And also I try to avoid the processed foods. I don't like going to the fast food restaurants. I don't like eating packaged foods. Now, granted, we're busy. You got to snack on things every now and then, but the majority of the foods that I try to eat are, homemade or purchased, in more of an organic fashion. And I tell my patients, I know it's hard, these can be expensive type foods, but you also got to realize what you put in your body can really affect you.
Right.
So
Agreed.
that's what I do.
So Dr. Hernandez, I'm going to take things back to you, because you are the first line of fire.
Of course.
You're the person that everybody comes to you, they give you all your problems, you listen to them, and then you figure out if you need to send them off somewhere else. Yes. So I would love for you to think of a case study or two, no names, of someone that you're like, this doesn't sound right, I'm going to order a colonoscopy for you. And what is it that patients are saying to you? Because again, a lot of the diagnosis first clinical, right? And clinical means ask all the questions, and what do you physically see? So what are some of those questions?
Yes, so what you just asked, it hit home, unfortunately. I have a family member, 40.
40 years old.
40 years old, no symptoms at all, a patient with no symptoms at all, just some, discomfort, bloatiness, mild weight loss, but not significantly. But at the time she was on a diet, so we thought, probably it's that. All of a sudden, she started with a little bit of blood in the stool, take her to the...
I'm going to stop you there, only because that's a big question in our audience. When you say blood, what does that look like? Because it could be dark, it could be bright red. So describe what she saw and what the symptoms could be.
Usually it's bright red blood. It all depends in the anatomy, where exactly the site of the bleeding it is. Usually the closer you are to the rectal area, there's more, it's gonna be more bright red blood. Mm-hmm. If you go a little higher in the upper GI system, stomach, the beginning of the small intestine, you can see black tarry stools, It's basically because in the way to the, outside the blood, it gets oxidized and it turns the stool black, what we call melena. So
we can even describe it, and I just think it's nice to say this out loud, that when you get a scab, it's not bright red forever. Like the bright red starts going away. So just think if there's a little bit of time there, your scab's going to turn a dark red even to a brown. Exactly. So that's what people are looking for if they take a little bit of time to get through the tract.
Exactly. Okay. And to be honest, there were not a lot of symptoms, to be honest. So when we took her to the colonoscopy, I was expecting everything but cancer, to be honest. When the doctor called me, this is the situation. It was already stage 3, according to everything they checked. But I was surprised that, believe me, there was no major symptoms. And I think that's the message, You don't have to wait until you have a rectal bleeding or bright red blood or blood in the stool. If you have symptoms like bloatiness, and they're very general, don't think it's like a excruciating pain. No, it's just mild pain.
There's something different. Something's off.
Something's off, and because of the diet we have here in this area, unfortunately, I'm very glad Dr. Walker talked about it, because I think the fiber, is out of a conversation. When you hear now in the social media and everything is about fat and protein, and people want to take more protein, but nobody talks about fiber. Yeah. And that's super important, I think, in this case.
I might just do the little shot before bed of Metamucil.
It'll change your life.
What? I bet it does. A story, but not. But when I was pregnant, I always would be nauseous in the morning. So I eat literally a boiled egg every night before bed, because that way I don't have an empty stomach. Sure. So maybe I may switch that out with a little bit of Metamucil, because then it keeps you a little bit full. Yeah. So it kind of
I want to emphasize the fact that, looking at your poop is okay. You know,
Let's
it's
talk
a big
about
deal.
poop. Like, this is the medical
I'm a
show,
poop
right?
doctor, and this is what I do. And I tell patients, look at your poop.
Right.
It's okay. It's got to look great. You got to be proud of it, and you got to look at and see what it look and what's in there. Okay.
You got to know your patterns. You got to
absolutely.
know, when.
Yep.
So on that note, so people who maybe have not yet ever looked at their poop, what's your poop supposed to look like? And again, this is something too. It's a little bit different for everybody. Everyone has a different system, a different clock, and that's all good.
Yeah.
But find out what your clock is. So what would normal poop look like?
That's a very good point to start off with. Everybody is different, but everybody should have a pattern, right? So if you go once a day and that's your pattern forever, that's okay. If you go once every 3 days and that's your pattern forever, that's okay. If that pattern changes for some reason over time, like a few weeks, and all of a sudden you're not going every day, that's a problem. That's one of those symptoms where it's like, now I have a change in my bowel habits. If your stool starts to have the dark colors, or if it's got blood in it, then that's a problem, right? If it changes shape, right? So if it should look like a nice S-shaped solid sausage, that's what should come out. You shouldn't have to strain. You should be able to sit down on the toilet. It should fall right out of your butt, and you should have a couple wipes and be good. That is the perfect poop.
Okay.
Okay?
Yeah.
And I tell my patients this all the time, and I ask them, how does your poop look? Half of them will say, I don't look. The other half say, it
You
does
know
not look
they
like
look.
that.
Everybody looks.
Well, they don't. And so, when you actually joke about it, they actually
loosen
so,
up, right.
So that's why I like to talk to my patients and have a good time with them talking about their poop, and they laugh, and we get more history in that sense. But you should be able to have a nice long, be proud of what your poop looks like, and then you can understand what changes might look like if they occur. And this really involves a lot of fiber. If you have good fiber, the stool should look like a nice sausage-shaped, S-shaped stool. Right. When you don't have fiber, that's when the stools become hard, or they become very loose, because the job of the colon, as we were mentioned earlier, is to absorb water. Right? That's the main function of the colon. And so what your body's going to do is it's going to absorb all the water it can, and then whatever's left is what comes out. If you don't have fiber to hold some of that water in, or to bulk up the stools, then that stool is going to be very thin, and it's going to be very watery, and then you're going to have the problems associated with that. If you have a nice, big, solid stool, you're not going to have the hemorrhoid problems, you're not going to have the constipation problems, and you're not going to have, hopefully, these colon cancer problems.
So on that note, and Dr. Hernandez, I'd like to ask you this, because there are times when either you eat something funny, or for whatever reason, it's like, okay, now I have diarrhea for a couple of days. Maybe it's a virus, maybe it's something I ate, well, now I'm kind of constipated for a couple of days. Like traveling, and I'll be the first one to tell you, I'm from Germany. I go home once or twice a year. I have an issue, like about 2 or 3 days. I'm an everyday pooper, just throwing it out there. When I go home, it's like it takes 2 or 3 days for me to have a bowel movement. And I'm like, years ago, I thought something's really wrong with me. But I don't know what the deal is on that, right? Yeah. But that's now normal for me. I get that. Yeah. So on that note,
I would argue, and I'm sorry to interrupt, but I would say that's probably not normal. If you can put that associated with your traveling, you're probably not either getting enough water while you're traveling,
probably.
or you're not getting enough the right food while you're traveling in terms of the fiber intake. Again, the goal of the colon is to absorb water. So if you're traveling and you're not getting enough water, your colon is sucking every ounce of water it can to hydrate your body, which leaves hard stools, which turns that into constipation. So the combination of fiber and water is probably the reason why patients have the IBS, why they have the constipation, why they have the hemorrhoid issues. All of these things are likely related to fiber and water.
Okay. All
and
right.
I tell the patients all the time, I say, how much water do you drink? Oh, I don't drink, I don't like water. Okay, right? There you go. Or I don't like the fiber, I don't like the fiber. Well, the best question, I love it, I have it every day. I say, how much fiber did you get? And patients say, oh, I don't know. I say, okay, tell me what you had for breakfast, lunch, and dinner. Okay, I don't eat breakfast, or I had a burrito for lunch and I didn't eat dinner. Okay, where's your fiber?
None.
And they're shocked.
None.
They're like,
yeah.
I really didn't get any fiber. Okay, and so if you're doing that every day, now you see why you're sitting in my office with hemorrhoids, or you're having constipation, or you're having very loose stools, because you're not doing the things that your body needs. You think about our grandparents. That's all they drank was water, right? You think about what they ate. They only ate stuff they could grow or go from the local grocery store, right? They didn't have these problems, right? And so now we're having these problems because we're not eating correctly in general. That's my theory.
Exactly. All right. Dr. Hernandez, so I would like for someone You're the surgeon, but I want you to describe a colonoscopy. And then we're gonna follow it up with some surgery questions. But I say this because some people that have never had a colonoscopy, oh, it's awful, it's really not bad. And I really want to say that out loud because I've had two of them. Okay. One was polypless, one has a polyp. So now, I do it every 5 years, but my own experience is you take your Go Lightly or whatever the preparation is, you literally have diarrhea for less than 24 hours. I call it a really healthy cleanse. Yes. Everything gets out of there, but that's the worst part of it, and it's not bad at all, like literally. But if you can describe to the audience the prep, yes, but then what is happening during the procedure so that when people hear it, they're like, okay, I get it now. Because you hear colonoscopy, they think you have to put you out, there's a tube going up you, like what does all that mean? So when patients ask you, doctor, what really happens in that room? What is it that really happens in that room?
Well, the colonoscopy, we have to see it as a gold standard, for the screening, for early detection of colon cancer. Basically, it requires for the patient to be under, a very potent laxative, because they want to cleanse everything. Because it's very important for the gastroenterologist or the colorectal surgeon to see the walls of the colon, right? So that's why it needs to be clean completely. A good preparation is essential to, have an excellent outcome in the colonoscopy, So I recommend my patients, to like 1 day before, just do liquid, just liquid so they don't, you don't want to eat enchiladas, the day before, and it's going to be a mess, with the laxative. So to do it more liquid, it doesn't have to be red, it's very important, especially, they can do some Jell-O, stuff like that. And the day of the colonoscopy, basically you show up. You are fasting, you have to be fasting at that time. Usually it's in a surgical center, in a hospital, or specialized center for the colonoscopies. They basically, after a good preparation, they take you to the OR and or the procedure room. And basically, yes, they put you under anesthesia. And basically the endoscope is inserted and go. This is very important because these tests, it can check the whole colon.
So describe for those that don't know, what is an endoscope? Describe what that piece of equipment is.
It's like a little camera, that it goes through. It's very thin. Don't think it's super. It's very thin, so it can go all the way. It's guided by this, in this case, colorectal surgeon or gastroenterologist, and basically they want to check the walls, to look for polyps. We're gonna probably talk about polyps, and that's very important, to check for polyps. But also, it's not only for polyps or cancer. You can find out diverticulosis, which is very common, and we go again with the problem with the fiber. That's one of the things with fiber. Here, believe me, if I tell you that at least in my, experience in my patients, at least, this is more anecdotal, but in my practice, it's at least 90% of those patients, they have or hemorrhoids or diverticulosis already. So all those things, those are important to check for that, Not only the colon cancer, which is basically the main thing, when you want to rule out, but there is also other pathology that it can show you during the procedure of colonoscopy.
Okay.
And
so Dr. Walker, yes.
Along those lines, I do colonoscopies myself. I did 4 or 5 this morning.
Okay.
And just like Dr. Hernandez was saying, it's very, very simple. You come in, you go to sleep, they put you to sleep, and you don't feel anything. It's actually a wonderful experience if you've never had anesthesia. And so basically, you go to sleep, you wake up, you get a report, and it's done. It's not a big deal. And the true benefit really of colonoscopy is getting rid of those polyps, because we know that.
So let's talk about, you're in there, you see a polyp, you got a little catcher at the end of the tube. So describe that.
Yeah.
I think that's super
So
important.
as you do a colonoscopy, you'll see these polyps, and we essentially cut them out right there through the scope. The scope is about the size of your finger, a little bit bigger than your finger. And you go in there, you see the polyp, you put a little, basically like a lasso, and you snare that thing and take it out. We send that off to the pathologist, and in 9 times out of 10, even higher than that, it's a benign polyp, and it's not a cancer by any means. But what you have done is you have prevented that polyp from growing to a cancer, and that is the key. You don't want to find a colon cancer because that means it's too late, right? Too late in the sense that you didn't prevent the cancer. You want to find the polyp because then you have prevented it from growing to a cancer. And so you do that, and based on the findings of how many they are, how big they are, determines when you need to get to your next one. And again, the prep is the worst part, but again, it's really not that big a deal. There are other preps out there that if you request it, we can make things happen. We can do things differently that might involve a little bit more, it might be more costly, but if you're not able to tolerate it. So there are things that if patients are worried about the type of prep that we can adjust and do things for. But yes, I do colonoscopies almost every other day, and we find polyps all the time, and this is very, very important to do.
Agreed, 100% agreed. What I'd like to do is kind of move a little bit and talk a little bit about hemorrhoids. So you were talking about hemorrhoids are the product of not enough water and not enough fiber. And the reason I want to bring those up is that we are talking about a symptom of finding blood in your stool. So the question can be sometimes upon a physical examination, if the hemorrhoid is what is bringing the blood to the toilet paper, again, look at your poop, look at the toilet paper, see what things look like. How do you describe that to your patients when somebody does have hemorrhoids? I don't want to say just hemorrhoids because they're painful. Hemorrhoids versus something that could be in the stool.
So
differentiate the two.
Let me kind of take this on because this is the number one reason I see patients.
Okay.
It's the main patient population that comes to see me is I have hemorrhoids. Gotcha. First of all, hemorrhoids are completely normal. They're part of your normal anatomy. I tell patients they're just like your left arm. Everybody has one, okay? The only reason why you wouldn't have a hemorrhoid is if you didn't have an anus for whatever reason, right? So they're completely normal. They're completely part of your anatomy. That being said, they grow and shrink based on what's coming down the tube. And that's because the hemorrhoids are basically the last little bit of closure of the anus, okay? So they grow and shrink in terms of what's coming down. If you have very watery stool, the hemorrhoid tissue is gonna swell up with blood and try to seal that anus so that you're not losing stool out your bottom. If you're straining and putting all this pressure down there because of hard stools and constipation, then they're gonna swell up too because of the pressure. Again, they're doing what they're supposed to do so that you're not stooling on yourself and they're reacting to what's coming down. So if you have nice, bulky, soft stools coming down because of the fiber, then the hemorrhoid tissue is gonna be normal and that's gonna not bleed and it's not gonna cause any issues. Hemorrhoids don't hurt. What hurts is when when a blood clot gets in them. Sometimes a blood clot can form and that can be very painful. There can be other anatomy or other disease processes within the anal canal that can cause pain, but hemorrhoids don't hurt. You can think of hemorrhoids like varicose veins. Varicose veins don't hurt. They get swollen, patients feel tired, their legs get heavy. You put compression stockings on them to help them go better. That's exactly what hemorrhoids are. They're vessels that are in the anal canal for a specific purpose. And so when they bleed, it's because you're doing something wrong. Are you wiping too hard? Do you have constipation? Are your stools too loose and they're swollen? Do you have a blood clot in there that's causing severe pain that we can treat right away if that's what happens? But again, hemorrhoids are completely normal. They're part of your anatomy and we shouldn't do things to them if they're not causing any problems.
Like you say, you shouldn't do things.
You said you had some issues when you were pregnant. Every pregnant woman has swollen hemorrhoids.
I never knew what they were
and
until I had a baby.
The reason why is because that baby is growing and sitting right on the big vein that's coming up from your legs. That blood's trying to get back up. It can't. It goes around the baby. And where's one place it stops? In the anal canal. So we get called all the time on these pregnant ladies with big hemorrhoids. And they say, what do you want to do? And I say, have the baby. And they'll go away. Why? Because they're normal. So I have this conversation. That conversation I just did right now is what I have every day.
Okay. I had no idea what a hemorrhoid was until after I had my baby. And then it's like, what is, again, too much information, but not so much because in this show, that's what it is.
Now, they can get very big and they can bleed a lot into the point where doing the things that are natural and normal won't help. And so there are interventions. They're very painful interventions. And so I don't like to do a lot of interventions on hemorrhoids, but there are things that I can do that aren't very painful that can kind of reset the system. And that's what I tell patients. I'm resetting your system. I'm not going to cure your hemorrhoids because again, they're like your left arm.
Exactly.
I'm not going to cut off your arm because it hurts, right?
Exactly.
We're going to find what's causing the pain or causing the issues or the bleeding. So that's kind of my hemorrhoid spiel.
Okay. So I'm going to pivot a little bit too because I want to talk a little bit about IBS because I feel irritable bowel syndrome because I feel like with the media we've heard a lot about it over the last decade or so. I used to say, well, that's somebody who has a nervous stomach. There's just something something always triggering and they've got gastro issues. What is IBS? I don't want to spend too much time on it, but Dr. Walker's looking at me like, do you really want to go there? Because it's a loaded question, and I am in full respect of that. But we hear it all the time. Some people are like, oh, I have IBS, and they kind of brush everything else off and say it's IBS. So who wants to tackle that first? Dr. Hernandez, it's kind of your turn to talk. You want to tackle that?
Yes, that's fine.
Okay, and then feel free to chime in on that.
Yeah. Well, irritable bowel syndrome is one of it's very common. You know, the incidence is very, very high. There is 3 types. One is it's irritable bowel syndrome. When you think about it, think of changing your pattern. You know, sometimes it could be more constipation in some cases. So it's IBS with predominance of constipation. There is also the IBS with predominance of diarrhea. And the other one is mixed, you know, and that's a little, harder to treat because you can have days of
that's
constipation.
what I'm saying, 'cause some people are just like, I'm this one day and this one another,
Yes, so it's one of those things that the best thing to do is what Dr. Walker, was mentioning about the high fiber diet, try to avoid, especially here in where we live, in our community, spicy food also, it can be irritant, to the colon and all this stuff. But basically, it's you can see a change in the pattern of the stool of the patients. One of the most things that the patients complain about.
Okay.
Yeah.
And the reason why I give you that look is because I can't operate on IBS, right? So as a surgeon, I like to operate. But that being said, I think when you sit down, and I think when the primary care doctors and the gastroenterologists sit down and talk with the patients with quote unquote IBS, if you get into their history and their mental history, their dietary history, and you get a real detailed, idea of what has happened in their life, you can pinpoint a lot of things to things other than their diet that might be causing this IBS symptoms. And again, I can't operate on it, so when they show up I don't typically see IBS patients in my clinic, but patients will tell me things like, oh, as soon as I eat, I gotta poop. I'm like, that's normal. That's not IBS. That's what's supposed to happen. Your body's having that reflex of time to get rid of. So, you have these discussions with patients and you find out that it's not necessarily a true problem. It's what you're eating or what's going on in your life. There could be some stress, there could be some anxiety that's a component of it. There could be some trauma back in the day that now is associated with these different types of situations. So, when patients come to me with this kind of complaint, that's kind of the discussions we have.
Do we want to talk about the vagus nerve at all in that when it comes to IBS? And the reason I'm talking about that is I haven't really heard too much about it in the last couple of years when we do colon type shows, that the reactions that our gut has and our gastro system in general, it's like nervousness does really matter.
Yeah, I think there's just not that much data out there on kind of how that really affects, but we do know that there's definitely a brain-gut connection that has a lot of effects on the gut and things that can occur. But again, I can't operate on that personally.
I can't operate on that. Dr. Hernandez, what I'd like to do is we did talk about a colonoscopy, which is absolutely, and I'll say this out loud to everyone in the room, it's the gold standard.
Yeah, it's the gold standard.
If for some reason, let's say, for example, I have 5 years before I'm supposed to do my colonoscopy again. But if I'm just kind of like, you know what, maybe in 2 years I want to do Cologuard, or I want to do, because again, we see advertisements right and left about other ways to do screenings. So let's just throw a couple of those out, but also keeping in mind that the colonoscopy, the only place that you can actually snip a polyp away is by doing a colonoscopy. That is on the table. But if there is somebody that is like, say you're 30 and you do have a family history, and maybe your doctor says, yeah, you're not ready for a colonoscopy yet, but maybe do A, B, C, and D. What are you finding in your practice with this subject is happening as far as screenings go?
Sometimes the patients, they want, sometimes they don't want to go to the colonoscopy, sometimes, and sometimes it's preferred. There is stool studies. One of them is FIT. Basically, what they're trying to find there, it's fecal occult blood, in the stool. They can see microscopic blood right there. There is another one, and it's very common. You just mentioned the Cologuard. It basically includes on top of the occult blood, they have biomarkers, 10 biomarkers of DNA, where they can diagnose colon cancer. They have effectiveness of 92%. That's what data says.
So say that they have an effectiveness of 92%.
92%
Okay.
to detect colon cancer.
Oh, okay.
But the thing here is what they're gonna miss probably is gonna be the polyp, that
Right.
it could be already with some dysplasia. They can miss almost 50% of it. So that's what marks the difference, between. So why do I recommend this instead of that? If you have a patient with no risk factor whatsoever and no symptoms at all, it could be a good option for them if they want to go that route. If the patient has symptoms, I think it's not the best way to go. I think it will be the colonoscopy.
Yeah, I just felt strongly we had to address it, because if we didn't address it, it'd be like, well, they didn't talk about it. So again,
And what I tell
something
patients
everybody
too is
hears.
like, if you get a Cologuard and it comes back positive, guess what?
Yeah,
You
go get a
still
colonoscopy.
So,
Exactly.
to me, I agree 100%. If they have no symptoms and they want it, more power to you. We can do that. But if you tell me one symptom at all, I'm pushing for a colonoscopy, because you're going to potentially miss that simple polyp, or that, maybe another disease process that's going on. Maybe you have an inflammatory bowel disease, an ulcerative colitis, or a Crohn's disease, or something going else that, is that we can identify on colonoscopy, as opposed to the polyp that you're concerned about, or the cancer that you're concerned about. So again, colonoscopy, gold standard all the way, 100% of the time.
So I don't know if and I don't think I've ever asked this question, how and why does a polyp develop? Does anybody know, or is it just one of those things, it's like your right arm, they may be there, they may not, we'll just see. But again, risk factors, food, diet, et cetera, et cetera.
Just like Dr. Hernandez said early, 15% or so of patients are genetic based. So they'll have some genetic component that may make them grow more polyps than anybody else. But that means that 85% of patients are sporadic, meaning these polyps just show up randomly.
and
we
you've
don't
had
know why.
one, that means you're probably going to develop another one.
Potentially,
Okay.
but not necessarily, right? There are probably genetic factors that are involved that we don't know about, that are causing these polyps to form. We know that as you get older, you have more chance of getting polyps, just like anything else in terms of cancer as you get older. But we know that polyps, the vast majority of polyps and the vast majority of cancers are sporadic and random, which is why we recommend it at 50, now it's at 45, to get your colonoscopy.
Okay. We've talked a little bit about diverticulitis, because Dr. Hernandez, you were talking about sometimes in the colonoscopy you will find that. Just quickly describe what diverticulitis is for those that were listening to it thinking, what is that?
Well, first of all, diverticulosis, they're like pouches, usually in the sigmoid colon in the left side. It could be the descending colon to the sigmoid colon. They don't have too many symptoms if they're not infected. Those little pouches, sometimes they can happen because of the diet, lack of fiber, water. We already talked about it already. So these, most of the time, they don't give you symptoms, but sometimes they can get infected, and that's when you start having the pain. It can be very painful, and
Are they infected because stool gets left in there? Is the stool not being moved out?
It's a very good question. And the problem is we don't really know why. We think that might be a reason, but the data on diverticulitis and the reasons why people get diverticulitis is currently unknown. And it's frustrating, because patients say, why do I get this? I say, I don't know. Patients say, how can I prevent it? I say, I don't know. I say, what you can do is the fiber, but we don't even know if that really helps. Yeah.
What is the treatment for diverticulitis, tuberculosis?
It all depends.
Diverticulitis.
It is itis. Okay.
Diverticulitis is what's infected,
Okay.
and it's swollen.
Okay.
And here the problem is there is two big problems that it can happen with it. One, if the formation of an abscess, and the other one is perforation. So that's why it's very important. If the patient has a lot of symptoms like pain, fever, they look sick. When they have diverticulitis, when it's bad, they look sick. So in that case, probably the best course of action is get a CT scan, and it all depends, how bad is the problem. But in that case, you can treat them. Usually, when they're mild, you can treat with oral antibiotics. Sometimes when you see more inflammation, perforation, or a possible abscess, probably need to be admitted to get IV antibiotics.
Okay.
And the interesting thing about diverticulitis as well is that the treatment is different all over the world, right? In Europe, they don't give antibiotics. They give some Tylenol and then they get better. And here we give antibiotics and we get better. And again, this is all the whole process of, we don't really know why, but we know that when you do get really sick, we treat them like you described with antibiotics. If they get really, really sick, then we potentially have to go to surgery.
Okay.
It's very individual based.
Interesting. Okay. Crohn's disease, that is a very specific diagnosis, correct? And how is that diagnosed?
Crohn's disease and ulcerative colitis falls under the inflammatory bowel disease. So this is something that I potentially
Okay.
could operate on. So this
Okay.
is something that I'm very interested in. Ulcerative colitis is a disease that extends from the anal canal all the way up to the potentially the small bowel. So it includes all of the colon. Crohn's disease can occur from the mouth to the anus.
Oh, that's right. I do remember that.
And there is no
Entire
cure
tract.
for Crohn's disease.
Okay.
Crohn's disease is treated with medicines. Now, if there are significant symptoms that can occur or problems that can occur with Crohn's disease that need a surgery, but most often it's a medical diagnosis, and you can treat that with special medications. Ulcerative colitis as well, you can treat that with these medications, but there is risk for long-term inflammation that can cause cancers, and you can actually cure ulcerative colitis with the surgery. But most of the time it's treated with a medicine. And these are all diagnosed, again, with colonoscopy. But these patients will typically show up with abdominal pain or bloody stools. When I see them in the hospital, they're really sick, they're bleeding, they are on a lot of steroids.
So there's no question. That is very symptomatic.
They're super sick, yep. And
Okay.
when I see them, typically, if they're being treated by the gastroenterologist, they're pretty mild symptoms. They're on these long-term medications, and they do very, very well. But sometimes about 10 to 15% of patients will need a big surgery and an emergent surgery kind of thing. And that can actually cure the ulcerative colitis, but again, Crohn's disease you can't.
Okay. So we are at an 11-minute mark before the show ends. It happens really, really fast. So at the beginning of the program, I said we're going to kind of stop questions from me, and I want you all to think about something that perhaps we've already gotten across, but you want to reiterate, or is there something we would like to talk about before we wrap up the show? So I feel like there's so much packed into the whole gastro system, the plumbing system, so to speak. But in general, Dr. Hernandez, have we not covered something that you would like to cover or something you would like to really emphasize?
Well, I think pretty much we cover what the primary care standpoint we do. I think what I want in a nutshell, if someone is watching your show right now, what they need to understand is one thing, that don't think that colon cancer, in this case that was the topic, is gonna have great manifestations. Don't wait, because a lot of times I talk to my patients that, you know what, it's time to do a colonoscopy. And the first thing that I said, no, I don't, there's nothing wrong with my poop.
So is there a lot of hesitation when you suggest colon? There really is. Okay.
I agree.
Okay.
There are.
So when you have a patient, they need to understand that in reality, you don't have to have bad symptoms like severe pain or a lot of blood in your stool. Sometimes it can be very mild, and that indicates that these things are already advancing. The colon cancers are advancing, and here the key is our early detection. Once you detect it in an early stage, the outcome is going to be a lot much better than when it's already in the later stage or it's already spread to other organs. So that's what is very important. If you have any symptom, GI, even if they're mild, like simple constipation, if you see a change in your pattern, I used to go every day, but now it takes me 2-3 days. And also my stool, the caliber, it was a little, more thicker. Now just small, and they mentioned just bolitas, like little pieces of stool. There is something that it doesn't mean necessarily cancer, but it's something definitely.
But check it out.
It needs to be checked, and that's in a nutshell. Go to your primary care, go to your GI, go to your colorectal surgeon, and discuss about.
And so I'm going to stop for a second there because most people don't know a colorectal surgeon. Most people don't know a GI guy. So super important to go to whoever it is that gives you your care.
Of course.
And I say that specifically in El Paso, in our region, because some people don't even have their internal medicine doc. So if that is the case, what would you say to people who are watching or listening if they've never been to a doctor before and they're 42 years old? That's not rare in this community. Where would they go and who would they talk to be that first person?
I think primary care,
Okay.
Usually it could be a family practice, it could be internal medicine. Usually we're the gatekeepers. When do you bring into the conversation the colonoscopy? Since the beginning. The first encounter that I have with a patient, there's a lot of things that I need to cover. First of all, it's family history. if there is a family history of colon cancer or family history of polyps, sometimes they'll tell you, you know what, my mom, she just got her colonoscopy not too long ago and they found some polyps. Chances are that you might have it, even if you don't have manifestation of it. So the risk factors, when you go to the review systems, one of them is the GI, you start talking about it. So there is a lot of chance for us, as a primary care to cover those. When you ask some questions, that's a hint to us that, okay, maybe there is something else here and something we need to go a little more profound and get a little more deep into it to see if there is a major risk factor for this patient.
And this is a subject too, people are shy about it.
I would reiterate the fact that, if you don't have a doctor, you can go to one of these urgent care facilities, right? You can go to the ER. I get called all the time, hey, this patient's here, they had some rectal bleeding and they're stable, but they need to see somebody because they don't have a primary. So if they go to the ER or they go to the urgent care, they can get sent to a primary care first, or they can get to my office, I'll get a call or whatever, but that's, I think, the best way to, get these kind of things figured out.
Right. So now we're at your turn. So is there anything that you want to talk about tonight that we haven't gotten to yet?
Yeah, I think we did a very good discussion here. I think one of the big factors is you got to be comfortable with your poop, and you got to be comfortable with your symptoms.
And be able to talk about it.
And be able to talk about it.
Yeah.
Like, it's okay, all right? It's our normal bodily functions that we have to say, this doesn't feel right, this isn't normal, I need to go get some help. And unless you do that, then you're gonna run into these problems where, I see these patients in the hospital and they never got a colonoscopy and it's too far gone and there's not much that I can do. So, if you have symptoms, the main thing is to talk to your doctor about it and say, this is not right. And if the doctor, unfortunately, if they're pushing you off, then you need to really go find somebody else who's going to help you, because it's a big deal.
Be brave,
yes,
and ask the questions.
It's okay.
Right. Yeah.
You shouldn't have these problems. They're not normal symptoms. Having symptoms is not normal. And so somebody needs to, help you out in that sense.
Okay. So I always like to reserve these last 5 minutes on what's new, what's coming up. Several years ago, we did an entire program on the pill that you can swallow that takes its time to go through the entire tract. And I want to say, if I remember it right, because we brought it up in the last show, but just briefly toward the end, that the camera would activate at a certain point in the system. Do you know about this pill? Is it something, and I say a pill, it goes all the way through. It's literally you're swallowing a camera and then it gets disposed, and then you need to be comfortable with your poop and go find it and bring it to your doctor. But what is that? Is that something that we're looking at? Is that something that was kind of a fad a couple of years ago that was talked about?
See, it's a tool,
Okay.
It's a tool. When you have a patient, for instance, that has anemia, or blood,
Okay.
and you do an endoscopy. The endoscopy, it goes to your stomach, to the esophagus, stomach, and they don't find anything. Then do the colonoscopy. They don't find any source of bleed. Then you have the camera that it can look into the things that not an endoscopy or colonoscopy can look into it. That's is one of the things we use for it.
Okay.
And you don't have to go find it. You have a little box and it records it all for you. So you don't have to go find it.
Oh, you don't have to go find it? Aw.
But it's okay.
I thought that would be half the fun.
No, it's okay. But I think one of the newer things that are coming around is, so I do a lot of robotic surgery. And there's a robot in town that you're able to do surgery with through one little incision. And this is going to be, I think, a game changer for a lot of these polyps that are big in the rectum, for example. We didn't talk much about rectal cancer.
No,
but,
we didn't. That's a good point.
But rectal cancer is different than colon cancer. But sometimes if you can find rectal cancer early enough, there are ways to remove it without needing chemotherapy, without needing radiation. And sometimes with this newer robot that's out here, we can resect it through the anus without any kind of incisions on the belly and cure that cancer before it grows to where you need a bigger surgery.
So you brought up a great point. So the rectum is how big compared to the anus of size? So literally when people, just visually.
So the anus is the very last part. It's about 2 centimeters in females, about 3 centimeters in males. That's the very last part of the GI tract. Then you have 15 centimeters of rectum above there, and then
15 centimeters. So that's pretty long.
Yep, it's about that long.
Okay.
And then the rest of the colon is about 6 feet of colon. Okay. So the rectum, though, is unique in the sense that it's in the pelvis. And so we can treat things differently when you have a cancer, for example. You can treat it with radiation, with chemotherapy. The surgery is a lot different. It's a lot more difficult. There are a lot more complications that can occur with rectal cancer. But rectal cancer is very unique in the sense that when you do treat it, there are certain things that can occur with rectal cancer that you don't get with colon cancer. For example, with radiation and chemotherapy, you can actually cure the rectal cancer without needing surgery. This is something that's becoming more and more common, where we see these tumors just disappear with the radiation and chemo, which is wonderful. We have these robots now that we can operate on through the anal canal and resect the tumor, and there's nothing that's needed after that, which is pretty amazing. We use these tiny little, robot arms. They go in there and cut it out. It's beautiful.
He is so excited.
It's what I do.
That's like,
it's the coolest
I'm like a 12-year-old, let me tell you. Right.
But so, these are the technologies that are coming up. And like I said, rectal cancer is very unique. And we could have a whole another hour talk on just rectal cancer.
And I remember when we used to combine those two, colorectal cancer. And I feel like in the last couple of decades too, we've really separated the two out.
Yeah, you have to, because they're treated completely differently. And so, and it has a lot more dramatic effects when you have a cancer in a rectum as opposed to the colon. There are blood vessels, there are ureters, there are bladders, there's uterus, there's vagina, there's all these different organs that can be affected, prostate, so you have to be aware of that. Takes a lot of different thought processes to treat.
Okay, very nice discussion. I loved everything about that. We have 2 minutes and 16 seconds, so this is like the lightning round, or I can just kind of wrap up. But I really want to say thank you to Dr. Arturo Hernandez, who again is a family practice physician with Hospitals of Providence, and then Dr. Avery Walker, who is a colorectal surgeon. Again, worked at Beaumont for a while, now with Hospitals of Providence. And this program is called Colon Cancer and the Importance of Early Detection. I also want to say thanks to the two Valerias in the room. So I never say hi to you guys. So when I say you guys, I know you can't see them, but the superstars of the PBS show that will record this is Valeria and Emily. And thank you so much. Are the ones that mic us up and make sure everything goes well. And if an ambulance comes by, they say, hold the show, we gotta do everything. Then we have Valeria, and then Rick, thank you so much for joining us. But if you wanna watch this program again, or any program that PBS El Paso does, you can go to pbselpaso.org, or if you want to watch this show again and or any show that the El Paso physician has put together for you, you can go to PBS El Paso, you can also go to YouTube, and you can also go to the El Paso County Medical Society site. And that site is epcms.com. And literally on the epcms.com, you will find the logo on there. Same thing with PBS El Paso, because that's locally recorded. Thank you guys. Doing this for 29 years. And on YouTube, just dial in there, the El Paso physician. What will happen is this program will pop up first because it's the latest one that's recorded. But if you're interested in knee replacements, or if you're interested in eye surgeries or whatever, you can kind of put that in the search engine and find those there. So that's always a nice thing to do. But I want to say thank you to you two very much. This has been the El Paso Physician. We are recording in the Turner home, which is the home of the El Paso County Medical Society, and it is over 100 years old, and we haven't seen any ghosts yet, but maybe one day. Thank you again for watching. This has been the El Paso Physician. I'm Kathrin Berg, and good night.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician television program to your home for the last 27 years on PBS El Paso. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.